Okay, so we're now going to move on to theme 2 of today's agenda, and that is putting policy into practice. And I'd like to welcome Dr. Amrita Jasarasa. Amrita is a consultant in public health and the National Lead for Prevention in Clinical Settings in Public Health Wales. Amrita's portfolio focuses on embedding prevention in the health and care system in Wales through a number of programmes of work, which includes social prescribing, the All Wales Diabetes Prevention Programme, and obesity prevention in primary care. After qualifying as a doctor from Imperial College London in 2005, Amrita initially trained in paediatrics before training in public health in Yorkshire and Humber. Amrita was appointed to her substantive post in Public Health Wales in 2020, and in 2021, Amrita commenced a NICE fellowship complementing her consultant portfolio as it focused on ways to embed NICE guidelines related to prevention in practice. Amrita is going to talk to us today about the social prescribing case studies. So over to you, Amrita.
Thanks, Claire. And if I can just share my slides and you let me know if they're working. Sorry.
That's okay. This is always the most nerve-wracking bit, is getting the tech to work, isn't it?
Yes, indeed. Right. Hopefully this will work.
Okay.
Yeah, just coming on there.
It seems to be coming up. There we go. Okay.
Brilliant. Thanks very much. So, diolch Claire, bore da pawb. Thank you, Claire, and good morning all. As part of the launch of the National Framework for Social Prescribing, Public Health Wales are publishing a set of social prescribing case studies, and it's a pleasure to talk to you all about these today. So case studies are widely used to help investigate, reflect upon and enable understanding of experiences and practices. We commissioned opinion research services to gather and generate case studies and used a multi-agency steering group to help develop these. The aim of these case studies was to demonstrate the real-life application of social prescribing in supporting individuals holistically with a broad range of physical, mental and social health and wellbeing needs. And the other aim of this of these case studies is to illustrate that the sources of referral into social prescribing are cross-sectoral in Wales and take a person-centred approach. So really, I think it should hopefully complement the explainer video in showing that what the ambition is of social prescribing is a reality in many parts of Wales, with lots of examples of this happening already. So to develop these case studies, we used the following approach. So we used a cascade process via our key partners to share with their respective organisations, networks and teams to identify both people in the social prescribing workforce as well as individuals who've used social prescribing. When we were selecting the case studies, we wanted to ensure that we had a sample that included a variety of roles, sectors, geographical locations and types of health and wellbeing needs that were being addressed. These case studies, the interviews were conducted virtually in May 2023 with an ORS researcher, and the focus of the interviews was really on different parts of the social prescribing pathway, including the reasons for referral, the referral pathways and processes, the types of support and services that people accessed, and we also identified facilitators and challenges to engaging with support. We then undertook a thematic analysis approach to identify, analyse and interpret the themes within the data. So this slide shows a bit of a snapshot about the case studies themselves. There were 14 in total. Starting in the bottom right-hand corner, you can see that there was a breadth of case studies in terms of who these who was interviewed. So there were social prescribing practitioners, those who are referring into social prescribing, those from working in the community assets that social prescribers might then connect people to, and most importantly, the individuals who were beneficiaries of social prescribing themselves. We tried to ensure that we had a geographical spread across Wales with case studies from Aneurin Bevan, Betsy, Cardiff and Vale and Cyntaf Morgannwg Health Board regions. And the case studies looked to identify support for physical, mental and social wellbeing needs. We also identified through all of the case studies and the different component parts that this really was cross-sectoral and in particular involving the third sector, the university sector, as well as the NHS. So we're really delighted to share a snapshot of the case studies that have been published today and some of the experiences that have been identified. These case studies have been anonymised, and so the names and ages used are just for illustrative purposes. And what we've shown is some quotes, so just some key quotes from a few of the people who had benefited from social prescribing. So David, aged 47, felt that his physical and mental health had been improved by rejoining the gym, and he's provided a lovely quote here when he's also been engaging much more in nature and in going for walks, and saying it really just is amazing when you're out there. He also plans to volunteer to improve his social well-being. Thomas, who was a student, was experiencing social anxiety, and one-to-one support helped him to improve this level of anxiety and his sleep routine, and by learning various healthier coping strategies. And this enabled him to focus more on school and consider employment opportunities. Gwen, aged 71, was a carer, and she was referred to a carers group which provided information, advice and support for carers of people with dementia, and it was lovely that she said that this really improved her well-being. And through these experiences, the recipients really felt that that was a positive experience with the social prescribing practitioner, that they were informed about different groups, interventions and services available, and they felt that the experience was encouraging, supportive and friendly. So from our case studies with the social prescribing practitioners, this really helped to identify the different component parts of what a social prescribing practitioner does. So firstly, they are involved in having a what matters conversation, which helps to identify, understand and discuss health and wellbeing concerns. This is really key to working out what support an individual will benefit from, and that people may present with one need but often require help with other things too. The next part of their role that's really key is around networking with those local community assets to stay abreast of what groups, interventions and services are available. And the whole process of social prescribing has really been demonstrated to be relationship based, and that these good working relationships with the community, but also through building trust with individuals to help them engage with social prescribing practitioners, is key. And moving on to some of our case studies from the referrers. Specific referrers we spoke to came from occupational therapy, general practice and frailty backgrounds. Our general practitioner highlighted that people often present with medical concerns, but alongside this, they often have general health and wellbeing concerns, and that most referrals relate to social isolation, housing concerns and financial difficulties. The other thing that was interesting about the case studies with the referrers is it really shows the breadth of different types of referrals coming in. Some of these are general, but others are more targeted. And in Cwmtaf, Morgana project tested the feasibility of applying a population health management approach to address winter pressures by using a proactive approach to finding and identifying individuals most at risk of the adverse effects of fuel poverty. Through this approach, frailty nurses and healthcare support workers telephoned individuals and engaged in a what matters conversation with them and undertook a needs assessment, targeting those at highest need first. Then looking at the community assets themselves. So this particular example focuses on feedback from an outdoor project manager. They work with local outdoor providers in Gwynedd to help them create wellbeing programmes. However, there are lots and lots of examples of community assets. And this breadth of community assets identified through the case studies includes, but isn't limited to, groups who help to increase physical activity, for example, through Dance to Health, guidance with applying for carers allowance, food bank vouchers and parcels, wellbeing focused arts and crafts groups, education, employment and training, for example, through helping with CV building, confidence building, training courses, online anxiety management courses and providing supporting resources. So whilst the case studies have identified the potential of social prescribing to meet health and wellbeing needs, perceived barriers and facilitators relating to the social prescribing pathway have been identified as well, and these have been categorised into 4 themes. So the first was around sustainability and funding, and for each theme there's really sort of barriers and facilitators. And the barrier with this was in relation to examples where funding has been either insufficient or short-term, affecting the availability and accessibility of community assets. However, to achieve greater impact, establishing an evidence base was suggested to help increase capacity levels to be able to support people for a longer duration. Within the referral process and pathways, barriers were identified in terms of the fact that this process and pathways can sometimes be complicated, that there can be difficulties with digital systems between organisations and inconsistency of feedback loops. So to overcome this, dedicated time to update the knowledge around community assets, access to detailed information about people's needs, and a collaborative approach with community assets were identified. In terms of understanding and awareness, it was recognised that there were some barriers to this in terms of a clear distinction about some of the organisation services and social prescribing practitioners themselves in terms of their exact roles, and public awareness as well about social prescribing. And in order to try and overcome this, improving communications about what services are available and how to access them could help more people with their health and wellbeing. And finally, it was recognised that the individual's own capability, opportunity and motivation can be a challenge, that psychological capability of people feeling hesitant to engage in a new activity or potentially having a physical barrier to engaging, for example, if the transport isn't available or reliable, and the timing and location of community assets can therefore really play into people's ability to engage with them. And again, in terms of the facilitators, dedicated time to discuss concerns, and for some people, digital services were considered as a positive way to overcome this too. So finally, I just want to say that we've only shared this sort of snapshot of the case studies with you today, but these have now been published on Public Health Wales's website, along with all the other links to the projects. These will be shared, and we hope that these are useful for you to share with your stakeholders and to help spread the understanding of social prescribing, and show that these are some of the examples of how social prescribing is delivered in Wales. Many thanks. Yeah.
Thank you very much, Amrita, and I really value the importance of case studies to demonstrate the impact that social prescribing can have on individuals and indeed communities. And you spoke there around that importance of the individual's experience and also looking at it really holistically, particularly thinking about how volunteering as well can improve people's well-being, help reducing any anxiety and improve social well-being. But I think the real key thing for me is around that public awareness of social prescribing, how to access it and the difference it can make. And hopefully those case studies, as we continue to share those, will help raise that awareness. So thank you very much, Amrita. We're now going to welcome back Carolyn, and we're going to keep Amrita and Carolyn. Amrita are now going to talk to us about the glossary of terms for social prescribing. Thank you both. I will hold on until the presentation is up, just to check. Yeah, I can see it, so I'll hand over to you both. Thank you.
Thank you. Diolch yn fawr, Claire. Before I start our presentation, I'd like to acknowledge all the work Dr. Simon Newstead has done to deliver this glossary of terms to you. Unfortunately, Simon can't be with us today. Thanks also to Public Health Wales, WCVA, University of South Wales, Health and Care Research Wales for their support, but most of all, the social prescribing practitioners and members of the public who participated in this piece of work. This has truly been a joint effort. The idea of having a glossary of terms originated from a member of the public in a PPI meeting with Prime Centre Wales Supergroup in 2018, where members of the group applauded the development of the original Wales Social Prescribing Research Network and the use of social prescribing in practice, but commented that the terminology was confusing and needed clarification for the public and for professionals. Otherwise, how were we to expect them to engage? For those of you who are not familiar with social prescribing in Wales, here, as you've already heard, it is an umbrella term that describes a person-centered approach to connecting people to local community. It can help empower individuals to recognize their own needs, strengths, and personal assets, and to connect their own communities for support with their personal health and well-being. Through engagement with this process, a diverse range of factors affecting well-being, such as loneliness, physical activity, or financial worries, can be addressed, thereby providing the individual with increased control over their circumstances. Despite using the term prescribing, the Welsh model of social prescribing moves away from the medical approach, as we've heard, instead of adopting a no wrong door approach where the sources of referral are cross-sectoral and not limited to healthcare or primary care. This seemingly simple concept flourishes with boundary-spanning social prescribing practitioners who work across sectors, communities and neighbourhoods. Within Wales, as in other countries, there's been a lack of standardisation and consistency in the terminology associated with social prescribing, and this diversity of terminology has resulted in potential for confusion amongst both the general public and workforce, impairing communication. In response, the glossary of terms presented here today has been developed to aid standardisation of language associated with social prescribing to improve its clarity and communication. It is hoped that this will be an informative reference tool for the workforce and for the public, all of those who access it. So what is it exactly? It's a glossary of terms which includes an interactive professional-facing document in PDF format with 36 suggested terms. It's an interactive, easy-read PDF as well with 22 terms. And this easy-read format was developed with support from Learning Disability Wales, and it includes the terms most likely to be encountered by those accessing social prescribing. Finally, the glossary is a dedicated website, which is currently receiving its final tweaks. This includes all formats in both Welsh and English. So how did we do this? We used 3 main methods to develop the glossary. We used a scoping review, a group concept mapping study, and numerous rounds of consultation with individuals with an interest in social prescribing. Exact details of our approach are available on request, and the first of a series of papers has been published. This slide shows an outline of the process of identification of social prescribing terminology and the development of the glossary of terms. The scoping review examined UK peer-reviewed articles and Welsh Grey literature. We screened over 46,000 paper titles and abstracts, resulting in 738 full-text screening for social prescribing terminology. We also included 42 Welsh Grey literature documents, after all of that, we identified 373 social prescribing terms. Just 1 or 2 then. We also used a GCM study to ensure we captured additional information from the social prescribing workforce of Wales that may not have been presented in the literature, and 49 terms were identified from there. Terms identified in the scoping review and the GCM task, the group concept mapping task, went forward for consultation and subsequently subcategorized into non-core and core terms. Latter stages of the group concept mapping study focused on the 192 core terms and utilise sorting and rating tasks to examine the relationships and strengths of relationships between terms, as well as to help identify their importance and relevance to social prescribing, both in general and by sector. We were then able to consolidate the 192 core terms down to the more usable list of the 36 suggested terms, from which the original professional-facing glossary was produced as the PDF. This in turn went on to develop the 22 terms within the Easy Read version and the glossary website. It's fair to say the largest proportion of articles and terms originated from England and the health and social care sectors, and these may not reflect the terminology commonly used by the social prescribing workforce in Wales. Many terms identified, described, or related to the same few specific elements of social prescribing. For example, the role of the social prescribing practitioner had 27. We identified some sector-specific preferences for terms, and although many terms are seemingly used interchangeably, there is with little standardization across and within services. So this slide illustrates the social prescribing pathway found in the document, which is only one tool which helps you navigate the glossary. It identifies the 36 suggested terms, which captures the core language and presents it in an informative and usable format. Most glossaries are a list of 25 to 50 words and often with no accompanying description. The diversity and complexity of the social prescribing terminology necessitated us using a different approach. So the glossary includes a description of the terms, the alternative terms, sector-specific preferences for terms, and where relevant, and the relationship of the terms to each other. The consultation feedback on the Welsh Government's National Framework for Social Prescribing, which occurred in tandem with the development of glossary, indicated that the term prescribing, as we've heard, was itself problematic to many who worked within the third sector and in which social prescribing is predominantly based in Wales. And consequently, the terms chosen as the suggested terms for use within the glossary reflect this feedback. Terms that describe the various assets on prescription, for example, art on prescription, are prevalent in the social prescribing literature, which is predominantly derived from published evidence from healthcare settings in England. However, such terms do not easily sit within the cross-sectoral model of social prescribing within Wales, and consequently, it was felt that referral or on referral were more appropriate. In some cases, such as exercise on referral, the term already existed in the literature. In others, the term was modified for the glossary to help unite the social prescribing language within Wales. For example, green prescription became green referral. These choices also reflect alignment with the terminology more commonly used by Welsh-speaking communities. For example, the term atgyfeirio at amgueddfeydd, referral to museums, and atgyfeiriad gwyrdd, green referral, and atgyfeirio at natur, referral to nature, are more commonly used in Welsh-speaking communities than the direct translation of museums on prescription, green prescription, and nature on prescription. The inclusion of terms in the alternative terms list and in the descriptions means that each one of these identifiable terms appears in the entries of the glossary. So, as I mentioned, that was only one tool, and the development of the glossary identified more than 400 terms in total and associated with the social prescribing process. And so you can see here that you can also access all of these terms through the navigation, the table, the pathway flowchart, the in-text links, connected terms list for the glossary term, and also the term mind maps. And you can just see an example, the shape of the example of mind maps. They're interactive within the glossary, and you can see there the address for the glossary, which is a unique name for the glossary of terms website. So let's give you a couple of examples. Let's take a look at the term social prescribing practitioner. The research indicated that the terms community connection and community connector were the most highly rated by social prescribing professionals within the third sector. However, across all nations of the UK, the term social prescribing and link worker were the most commonly used. Although the term link worker was well recognised, it was felt that promoting link worker as the suggested term of use would ignore the prevalence and importance of the terms, as we've mentioned, within the social prescribing community in Wales. Therefore, the glossary adopted social prescribing practitioner as an umbrella term and highlighted sector-specific preferences for alternative terms within the glossary entry. To ensure the glossary of terms is as accessible as possible, the terms needed to be accompanied by the description. You can see there the description, which is below the actual term, which is in black on the top left-hand side. So we adopted a description over a definition, as it allowed for the incorporation of contextual information. And the description was also considered more suitable as the language associated with social prescribing and how that language is used across regions and sectors presented certain challenges for several terms. So the use of a description also acknowledges the evolving nature of the language associated with social prescribing, and the descriptions were initially obtained from the scoping review literature and refined to align with Welsh Government policy. And you can see here within this example that you'll only just be able to see that next to the social prescribing practitioner term at the top, you can see the source of the consultation, the group concept mapping, and the scoping review is identified. So you can also see that we've got links within the description to other terms such as the what matters conversation, co-production and action plan. Below that description, we've got the alternative terms, which are also in the superscript identified the sectors where they're relevant to. So you can see community coordinator there has got an SC superscript by the side of it, which denotes that it's most commonly used within social care sector. So, and below that again, you've got the connected terms, which have also got links with their descriptions. And the second example I've got is where we see the what matters conversation. It's superscript again, identifying where the evidence for its inclusion was found. Here, the GCM and the scoping review. Its description, the alternative terms, for example, well-being conversation, with its superscript identifying that it's a term used in social care. And finally, its list of connected terms. And here's the glossary for you to see. It's, as you can see, it's in both English and Welsh, and it has got a number of interactive aspects to it. Amrita.
Thanks so much, Carolyn. It's been a real pleasure to collaborate with Carolyn, Simon and the team at the University of South Wales on the development of the glossary. I think it's fair to say it's been a bit of a labour of love. It's been a real kind of exploration into language and the importance of language. So I think what we really wanted to highlight was this kind of evidence into practice lens of the social prescribing glossary. So firstly, as Carolyn's highlighted, that it has been developed collaboratively with those involved in social prescribing across Wales, recognising the need for it to be usable by those in practice. So that has happened along the way, and we've ensured that's happened as part of the process. And the purpose of this is to provide that common language to help improve consistency, facilitate a shared understanding, and support that high standard in line with the goals of the national framework. However, we completely recognise that language evolves, and therefore the utility of having this glossary is really high, because that can be continually updated and reflect how language does evolve and concepts and understanding evolves. There's been a real challenge to agreeing and utilising some of the common descriptions of the terms, and that we experience that in English as well as in Welsh, and recognise that that's therefore likely to be a challenge in many, if not all, languages. And much debate was needed about this terminology, and so we recognise that this is likely to be the case in other languages too. And related to this, we've been in contact with many international colleagues about the developments of the national framework in Wales, including the development of the glossary, and hope that this will also be a useful process for international colleagues in developing similar shared language in their countries. So just to finally conclude with the next steps for the glossary, and these include incorporating these terms into the further developments of the national framework, including the commissioning guidance, so that we can really start to see that consistency of terminology and help people to have that shared understanding and try and remove some of the ambiguity by having that common reference point. Carolyn, I'll pass back to you, but just to say thanks again to yourself and the team in USW for the collaboration.
And thanks, Amrita. It's been a real pleasure. I want to reiterate that, a real pleasure to have worked with everybody. You know, and it's been a good journey, a good example of how academia and practice can work together. Thanks, Claire.
Thank you very much both, and please do pass on our thanks to Simon as well for all the work he gave to this piece of work, which has been substantial. You know, when we first started talking about the framework and the number of different terms, and even in practice, you know, when speaking to other practitioners, it really was a minefield. And I'm loving the adoption of splossary. I think I'm going to be using that quite a bit going forward. So thank you both. We will be having a comfort break shortly, but just before we do, I'd like to welcome Chrissia to today's presentation. Chrissia is a member of the Workforce Transformation Team in Health Education and Improvement Wales, HEIW. And working with partners across Wales, Chrissia's work is dedicated to workforce development and education transformation. Looking at supporting the workforce that is responsive to change and to enable the best possible care for individuals. Chrissia is now going to talk to us about the competence framework for social prescribing practitioners in Wales. So over to you, Chrissia.
Thank you, Claire. In the usual way, can you just make sure that my presentation comes up?
Yeah.
It's always a worry, isn't it, this bit?
It is.
So let's have a look. Click on there. Ooh, is anything happening?
There we go. Yes, it's there. So over to you.
You've got it before I have.
Oh.
Oh,
yeah.
Okay, here it comes.
Okay.
Right, okay.
Thank you.
Right, thank you for the introduction. And thank you for the opportunity to share the work that I've been developing. So I'm here to talk about the competence framework for social prescribing practitioners in Wales. And as Claire's mentioned, I'm a workforce programme manager in Health Education and Improvement Wales, HEIW, where education is our business. So social prescribing is being adopted in policy and practice across the world and in different health systems and different contexts. This report on your screen now was published this year by the Global Social Prescribing Alliance, the World Health Organization, and the National Academy for Social Prescribing. It developed a series of case studies from 24 countries showing varying maturity in social prescribing implementation. What stands out, certainly for me, in this report is that there is no course set or a standard set of qualifications that outline the role of a social prescribing practitioner. So I feel that we in Wales are leading the way with an extensive and deep dive into the detail of the role of a social prescribing practitioner. So my presentation, and what's it all about? Well, as I typed this title, it brought to mind a book by philosopher Julian Baggini is his name, in which he succinctly breaks down 6 answers people commonly suggest when considering what's it all about. Just to note for the audience that his question relates to the philosophy and meaning of life rather than my slide set. The 6 answers that people give are helping others, serving humanity, being happy, becoming successful and enjoying every day as if it were your last, and freeing your mind. Now, from a social prescribing perspective, this certainly resonates with me, and I can see how it relates to those involved in delivering social prescribing and wanting to help others directly, service developers and commissioners who want to provide the right service at the right time to meet people's needs, and for educators and learners alike wanting knowledge and understanding of the how-tos of making people's lives better. So that's what my presentation is all about. It's about our people, our workforce, whether social prescribing may be an individual specific role or an incidental element of it. So this framework is about targeting proficiencies. I'm sure we all remember that proficiency test, learning to ride the bike. So what is the proficiency test when learning to ride that social prescribing bike, as it were? I'm going to start with some definitions. Competence, the ability to do something successfully or efficiently. Incidentally, the term competence is not a new buzzword. The use of the term, has increased steadily since the 1940s. But its origin in text, according to the Oxford English Dictionary, was actually in the 16th century by Richard Carew, the Cornish poet and author. There he is, just popped up on his screen to join us. He was an intellectual with an avid interest in language. He wrote The Excellency of the English Tongue. His interest led him to some verbal sparring with the likes of William Shakespeare, no less. Similarly, in the development of my product here, there was also some verbal sparring during the course of its build-up. But all good products need a bit of a challenge along their development pathway, so no harm done there. So to be competent is the ability to perform to a specified standard. Competencies are the knowledge, skills, abilities and behaviours that contribute to individual and organisational performance. Knowledge is information developed or learned through experience, study or investigation. Skill is the result of repeatedly applying knowledge or ability. The framework is designed as a clear set of these proficiencies that identifies what sort of activities the social prescribing workforce should be capable of and at a defined level. So, for instance, for service commissioners, what can be offered to meet the needs of a population, outlining standards of care, value and quality of services. For an employer, the framework helps define what they want their staff or their team to be able to do. And for the social prescribing practitioner, there is clarity around what is required of them and a pathway to the development and career aspirations. And then educators, the framework will provide a structure and language in which professional standards can be defined and outline essential elements for an appropriate teaching programme. So although there is an abundance of training that is readily available, I've done the scoping and I know that that is true. That training ranges across academically accredited qualifications, short courses, continuing professional development, e-learning packages. However, there is not a national or Wales framework that addresses the core skills and knowledge required to equip the social prescribing workforce to provide that personalised, high-quality social prescribing service. So we set out on a journey to address this, and this is what we did. We convened a steering group comprising representative members of key stakeholder groups with reach out across all sectors where social prescribing has significance and value. We've already mentioned these key stakeholder organisations. We have Welsh Government, Public Health Wales, University South Wales, the Wales School for Social Prescribing Research, WISPR, and the Wales Council for Voluntary Action, the WCVA, and of course my own organisation, Health Education and Improvement Wales. A procurement exercise was then undertaken to source the best contractors who could provide the expertise and guidance on competency framework development. The team from the National Collaborating Centre for Mental Health, the Royal College of Psychiatry, did a sterling job of providing framework structure, listening to the steering group's requirements, issues and concerns, and bringing in expertise from across Wales into focused discussions to continually inform and improve the framework at each stage of its development. An all-Wales consultation on the competency framework was then undertaken, giving opportunity for input from a much wider audience. A major point raised by respondents to the consultation was that of the use of complex language and not of simple English. Subsequently, the competency framework documents have been edited using an approved plain English tool and cross-referenced for consistency with the glossary of social prescribing that you've just been hearing about. What does it look like then, and how will it work? Firstly, the competence framework is not a mandate or a guideline. It is hopefully a helpful resource that will benefit individuals, employers, educators, service managers and commissioners. The framework aims to be flexible and adaptable to local organisations, circumstances, geography and resources. The framework aims to be applicable to an individual's development and career pathway, applicable in performance management and in development planning. Firstly, there is an overarching core philosophy that it is person-centred, strengths-based approach that aims to empower that it is a person-centred, strengths-based approach that aims to empower people, that shared decision-making is at its core, and any action plans that emerge are co-produced on an equal partnership between service users and practitioners. And then we have the building blocks of good practice. 6 domains outline a common currency of knowledge, skills and behaviours, and providing a set of working behaviours for social prescribers which align with core values to help develop the right skills of all individuals at all levels. We have knowledge, professional and legal issues, networks and partnerships. And we have communication skills, action plans, following through on these actions, monitoring and evaluation domains. Completing the competence framework is a set of meta competences. So where the core philosophy umbrellas the whole set of competences, the meta competences are like the inner lining, if you like, of the framework, that added extra that comes with experience gained. It's the ability to anticipate and to adapt. These are the competences that involve making decisions relying on experience that becomes intrinsic and instinctive. It's what we can call making judgment calls. So in a summary graphic, the competence framework looks like this. The core philosophy, the dark green block on the left, applies across all the competencies. The 6 domains and their interrelationships are shown here. And then the 7th domain, the meta competencies, these culminate as knowledge and expertise is gained. Then delving deeper into the framework, each high-level statement is expanded into specific competence statements. It's at this level of detail that will enable an individual to evidence their ability or knowledge, a manager to assess their team's skill set, an educator to develop an appropriate learning programme. There is clear research, we've already heard from Professor Carolyn Wallace on this, that across Wales there are significant differences in the way that social prescribing is organised and delivered. 4 levels have been identified. So we have signposting, and that's an example is a receptionist in a GP surgery helping patients navigate health and care, for instance. Then we have light and medium signposting and prescribing, which could be a referral to a specific programme or intervention, for instance, the National Exercise Referral Scheme, or support across a range of areas that may include physical and psychological well-being within a specified time frame. And then 4th level, holistic, providing a broad range of interventions and connections further to a holistic assessment of a person's needs. Services also vary in relation to geography, for example, rural versus urban settings. In organisational context, for example, the voluntary sector rather than the health sector, and whether practitioners are working alone or as part of a team, whether services are commissioned or whether they have to seek funding for their own positions. This variation means that the competence framework needs to be treated as indicative and not prescriptive, and adopted to reflect local organisation, resources, aims and objectives. For example, not all social prescribing practitioners would be expected to contribute to building community assets or to develop a business case. However, both areas are included in the competence framework. The competence framework is designed as an explicit set of competences that users will tailor for their specific needs, be that individual, team or service need, such as training, commissioning, supervision, etc. The competence framework package is in two parts. There's a supporting document that describes the purpose and how to use the framework, and then the detailed set of competence statements under each domain heading. The resource will be made accessible via an online link. However, there is a further phase of development that is crucial if we want to make this resource functional and to maximise its value. Phase 2 of this development is the mapping of existing education and training to the framework, then identifying any gaps that may exist, and subsequently developing the learning resources to address these. Ultimately, it's envisaged the competency framework will actively enable assessment of an individual's skills or a service provision, and will help identify a development or improvement pathway with access to appropriate learning and development resources. A link to access the resources it currently stands will be shared with delegates after this event, but please continue to watch this space, as they say, for its ongoing development into what will hopefully be a digital competency framework and a potential e-portfolio for social prescribing practitioners. And diolch yn fawr, that's me done. Thank you.
Thank you ever so much, Chrissia, and really important for us to understand those building blocks of good practice and the different elements within it. So thank you for all your work on that and the importance of developing the skills and knowledge of social prescribers. Really interesting to hear towards the end where you said that it's indicative and not prescriptive, but I would encourage everybody to take the opportunity to look at this important piece of work and how it might help them to develop their own practice. And let's face it, the people and workforce are absolutely key to delivering against this framework. So thank you very much, Chrissia. Okay, so we are now going to be moving on to theme 3, which is the experiences of social prescribing. But first, we will be taking a 5-minute comfort break. Please do come back. Obviously, we've had a lot of talking to you this morning, but as we move into the next phase, we will be sharing a number of wellbeing videos with you, which I'm sure you will really enjoy. And we will also have our 2 panel sessions. So the Welsh experience of social prescribing, where we have panelists joining us, and we will also have our international panel discussion as well. So if everybody could be back at 11:41, that would be fantastic. Thank you.